Today, half of the part, I would say 50% of the time, initial 30-35 minutes, we'll be discussing about the hyperthyroidism. I would say less than that time. And remaining main time will be going on to the management of Graves' disease. And in short, at last, about the management of other causes of hyperthyroidism, the common one, I think. I mean, okay. So the main source of like discussion in the today's topic is from the ETA, that is European Thyroid Association guidelines for management of Graves' disease. Okay, which came in 2018. Okay. So before starting, or before actually moving on to the Graves' disease management, before that, I should discuss a bit about thyrotoxicosis and hyperthyroidism in general also. So this is like very commonly used words. Frequently they are used interchangeably, but theoretically speaking, they are not same. Okay, so by definition, this is very simple. Thyrotoxicosis is the state of, I'm like not the book definition. I'm like making a simple, logical, understandable definition. Okay, so state of T4 or T3 excess. Basically, it's a state of thyroid hormone excess. Thyroid hormone excess. Okay, so basically, it will include all the state, all the cause where you have excessive T4 or T3, whatever. Okay, so this is a state of thyroid hormone excess. Hyperthyroidism at the other end is basically it is obviously T4 T3 excess, but remember, it is because of due to increased production of hormones, obviously thyroid hormones, from thyroid tissue. Now there may be some mild difference between different books and sources, but in general, when I say thyroid tissue, it could be thyroid gland per se, or ectopic thyroid tissue, or it may be even metastatic thyroid tissue, or it would be thyroid tissue present at some abnormal places. Okay, so in general, it is because of increased production of hormones from the thyroid tissue. uh, what is the importance of like knowing this differences? When we say thyrotoxicosis includes all causes, not just increased production, it also includes the, see, for example, I'm just giving an example, typical example of subacute thyroiditis, where the excessive T4 or excess T4 T3 is because of increased release of preformed hormones. Okay, so that is the base of different. When we do a nuclear scan or scintigraphy of thyroid gland, this is a difference where it comes. So we frequently have low uptake in the scintigraphy in some cause and high uptake in some other causes. We'll be seeing that also later on. So I hope the idea should be very, very clear. Thyrotoxicosis includes everything. Hyperthyroidism includes only those where we have increased production of hormones. Okay. Now, this is from the Harrison. This is very like simple and logical. Nothing, not much like to be understood. So it's as simple as everybody knows. This is the single most common cause of hyperthyroidism. Okay, and per se even thyrotoxicosis also. Other common causes include this toxic MNG and toxic adenoma. So basically, it's the autonomous release of the thyroid hormone, which is without the control of the TSH from the thyroid gland itself. Toxic adenoma is single lesion, and toxic MNG or toxic multinodular goiter, you have multiple autonomous functioning nodules. Okay, I told you that even the thyroid carcinoma metastasis, which is functioning, which is actually uncommon. Thyroid carcinoma, obviously, it's a common cancer. Metastasis is also common, but functioning one is less common. Okay, so if it is functioning, then we call it as primary hyperthyroidism. Then these are some genetic causes. So I'm not going to detail of much of a detail, but it's just to complete the list. So activating mutation of TSH receptor, something, this is something called as familial gestational hyperthyroidism. Okay, so this is not a very common, this is a very rare condition as such. And we have McCune-Albright syndrome, where we have involvement of multiple parts of the body, including bones and even the adrenal gland and many more organs. Okay, then you have struma, or even typical cause. This is like very typical cause, though not a common cause, where you have thyroid tissue in the ectopic not per se in other organs. Especially most typically it is described in ovary. That's why it is called as struma ovary. So ovary. So ovarian tissue mostly it is like mostly you have a benign tumor of ovary. Mostly it's a teratoma which has thyroid tissue in it, and it secretes thyroid hormone and leading to thyroid excess state in the body. And this is like we have been studying this since our physiology first year. Iodine excess, that is Jod-Basedow phenomenon, which is reverse of the Wolff-Chaikoff effect. Wolff-Chaikoff effect leads to hypothyroidism. This leads to hyperthyroidism. Now, something to understand: thyrotoxicosis without hyperthyroidism. I just told you. So basically, the here excess T4 T3 is because of the release of preformed hormones. One typical causes of acute thyroiditis. This is painful. Silent thyroiditis, which is painless, and other anything which leads to destruction of thyroid gland. One typical cause being amiodarone induced AIT, something called as amiodarone induced thyrotoxicosis. So typically the type 2 one, type 2. Okay. Then radiation, it can lead to destruction of thyroid gland, same infarction of the adenoma. And one very, very important cause. So factitious thyrotoxicosis, where what happens is usually a pharmacist or a nurse, what they will do for weight loss purpose, they will take T4, I mean the thyroxine preparations for that purpose, and they may develop thyrotoxicosis factitia. Okay. And last, secondary, when I say secondary, it means we have something uh, which is stimulating the thyroid gland. Obviously, it will be TSH or TSH like substances. So it would be first TSH secreting pituitary adenoma. So I would say this is the only cause. This is the only cause of hyper, I would say, thyrotoxicosis in general also, where you have increased, or I would say high normal, increased TSH. Rest all other causes have low TSH. This is like logical. Okay. On all other states, you will be having low TSH levels. This is the only condition where you will be having clinical features of thyrotoxicosis and increased TSH. It's a very, very rare condition. Obviously, not a common thing. And we have, I just told you, TSH like substances. HCG typically has some part which is similar to TSH, so it can stimulate thyroid gland. HCG can act like TSH. Same thing. This is the same thing. Gestational thyrotoxicosis. Okay. So this should be very, very clear. So this is the only condition I would say where you have TSH secreting pituitary adenoma is the only condition where you have increased TSH and symptoms and signs of thyrotoxicosis. Okay. Now coming on to the next clinical features. I'm not going to discuss everything in detail, just superficial things. So everybody knows patient will be having symptoms because of excess thyroid hormone, which has increased sympathetic activity indirectly. So hyperactivity, irritability, dysphoria, heat intolerance. So many times patient may have even fever-like symptoms, excessive sweating, palpitations, no doubt fatigue, weakness. Usually it is weight loss with increased appetite, though sometimes weight loss with decreased appetite can also occur, but usually it is typically described as weight loss with increased appetite, diarrhea, polyuria, and you have oligomenorrhea and not menorrhagia. Menorrhagia is more common in hypothyroidism, but oligomenorrhea is more common in hyperthyroidism. These are the symptoms. You have many more symptoms, but this is very overview only. You have signs, may it will be like the symptom related. We have palpitation, so patient can have tachycardia. Many patients develop atrial fibrillation, and this is obviously proportional to age. More the age, more the likelihood to get atrial fibrillation. The tremor, usually it is fine and positional, or I would say postural tremors. And so basically, there are the exaggerated physiological tremors. Okay, tremor can be also seen in tongues as well as hand. Okay, then goiter, obviously, warm and moist skin, muscle weakness, frequent proximal myopathy. This can be seen in both hypo and hyperthyroidism. Then you have lead retraction. So many signs, eye signs because of excessive, many eye signs because of excessive T4, T3 leading to excessive sympathetic stimulation. Okay. And there are some signs which I will say. So these are the signs apart from the Graves ophthalmopathy or Graves dermopathy, and you have gynecomastia. Okay, remember this thing. So When I say involvement of eyes, it is called, technically it should be, it is nowadays called as Graves orbitopathy and not Graves ophthalmopathy. Okay, so why I'm saying this? Because Graves disease typically involves the whole orbital cavity, not just the eyeball. I would say more commonly it involves the extraocular muscles, the intraocular tissues, soft tissues. That's why leading to proptosis, chemosis, then periorbital edema. Okay, so the signs like mydriasis, signs like lead retraction, some signs are because of sympathetic stimulation, which are not the part of Graves orbitopathy. But so basically, when I say Graves, it is only seen in Graves, only in Graves, because it is secondary to autoimmune phenomenon. While in any other cause of thyrotoxicosis, the signs like lead retraction and all those signs can be seen in any cause of thyrotoxicosis. Okay, so pain in the eyes, redness, then diplopia, then you have last me you can have vision loss, etc. Okay, so I just wanted to like say, or in short discuss about Graves orbitopathy. When I come to management, I will again discuss this part. Okay, so basically whenever you have a patient who comes to you with signs symptoms of thyrotoxicosis, it's important to actually take history. Why I'm taking history? Because history will many time help you in knowing the cause of the disease, though you actually have to prove after doing some investigations. And second thing, if patient whether the patient is having Graves ophthalmopathy or not, because the management or some treatment will get modified when you have the involvement of the eyes. This is very important in terms of Graves disease. So any symptoms or sign of thyrotoxicosis will be seen in any cause, but these three, that is Graves ophthalmopathy, Graves dermopathy, and Graves or acropathy, or also called as thyroid acropathy, will be seen only in Graves disease, only in Graves disease. Okay, so basically now I was going to discuss this only. Earlier we used to have the classification called as no specs. Okay, now actually we have one more classification. No specs actually not used. Why? Because the new classification is basically based on the management purpose. So how actually the classification will define the management, that's why we have a new classification. Okay, so remember, when we are dealing with Graves orbitopathy, we look for two things: one, the activity of the disease; one, we look for the activity of the disease; and second is the severity of the disease. So what I mean by this? So why this is if only if the patient is having active disease, then only will the immunosuppressant will help. But severity is different thing. So patient may have active disease earlier in the past day, before 6 months, before 12 months. Now the patient has developed some complication, or I would say the chronic features of that activity. So for I'm just giving one example. A patient develops diplopia today because of the edema of the muscle, and after 6 months that edema resolves, patient is not having any pain, but because of the fibrosis of the muscle, now patient will be having diplopia. So this is basically the activity of the disease decides the need of immunosuppression, while the severity of the disease will decide the need of surgical repair. Okay, surgical repair. Okay, so this is what I was talking about. This is the no specs classification which earlier was used. So it's basically no physical signs and symptoms, only signs, no symptoms. Then you have S for only soft tissue involvement. Then we have P for proptosis, more than 22 mm. Now, actually, this all things are not commonly used, but still we have to remember the name. E is involvement of extraocular muscle, so patient will be having diplopia. C for corneal involvement, and last it is involvement of optic nerve. Okay, so this is called as dysthyroid optic neuritis. DON. Okay, DON. Okay, so Just for naming purpose, you can remember this classification. Otherwise, remember the stain. This is very simple. So basically, class. This is the UGO class, Uh, European guideline of Graves orbitopathy study. The study was done and they found this classification. They described this classification. Why I'm telling this? Because this will decide your management. So based on the severity, that is mild, moderate to severe, or site threatening, this classify based on this three classification. The patients are classified, and then the management will be decided on the basis of this. This is the severity. Remember, I'm just telling this is severity classification, not the activity. Activity depends on something else. Okay, so this is either the site threatening. When it says site threatening, it is the most severe part. It includes this or this. So either this thyroid optic neuropathy and or corneal breakdown. So corneal perforation, corneal rupture, everything which is causing corneal breakdown will lead to will be included in site threatening Graves orbitopathy. Okay, then you have moderate to severe Graves orbitopathy without site threatening, but they are actually the symptoms or signs are such that they have an impact on daily life. So significant impact on daily life, like any one of this: lead retraction, moderate to severe soft tissue involvement, exophthalmos, that is proptosis for at least 3 mm above normal for the race and gender, inconstant and constant diplopia. So any one of this uh, will make us think of the diagnosis of moderate to severe. And mild is obviously this 1 and 2 won't be there. So only minor lead retraction, mild soft tissue involvement, exophthalmos less than 3 mm, transient or no diplopia, corneal exposure, responsive to lubricants. Okay. Okay, friends, I hope this is very clear. So in this way, we'll define Graves orbitopathy into three: side threatening Graves orbitopathy, moderate to severe Graves orbitopathy, and mild Graves orbitopathy. This is severity. Now we have the activity classification. This is called as clinical activity index. Okay, this is called as CAS, or clinical activity index. Now, these are the 7 main clinical symptoms or sign which will be we should take into account to consider the clinical activity. So first is present of the eye pain, gaze evoked pain, eyelid swelling, that is considered to be because of the Graves orbitopathy. Then the eyelid erythema, okay, is different. Then you have conjunctival redness due to active Graves orbitopathy, chemos, that is conjunctival edema, and the inflammation of the caruncle or the plica. So all these are given 1 point. Okay, all these are given 1 point. So if you have more than equal to 3 out of 7, okay, if we have anything more than equal to 3 out of 7, this is considered as active disease. Now, for example, this is for the patient who has present for the first time. Now you have given the treatment, or you have patient is being followed up. In that case, these 3 also can be added. Increase, so you need to have some baseline value: increase of more than 2 mm of proptosis, decrease in the uniocular ocular exertion in any one direction of more than 8 degree, and decrease of acuity equivalent to 1 length. These are also given 1 points. So this is more than equal to 4 out of 10. So on follow-up, if it is more than equal to 4 out of 10, and at the initial diagnosis, if it is more than equal to 3 out of 7, this is considered as active eye disease. Okay, so based on this, we'll be having 6 ways. Either you will be having mild active or mild inactive. So I hope now this is very clear. What is the difference between severity and activity? Then we have moderate to severe active disease, eye disease, moderate to severe inactive Graves orbitopathy. Similarly, we have sight threatening. So sight threatening is going to be active only. You cannot say it is inactive. So this is very logical. Okay, I hope this is very clear. There should not be any doubt about this thing. Okay, now just moving before moving forward, I wanted just no need to remember, just I just had for seeing purpose I have put this here. Just remember that we have some scale which is called as Birch Wartowski. This is the Birch-Wartowski point scale for the diagnosis of thyroid storm. Based on the symptoms and signs, we have a score, and we'll get this score from this. If it is more than equal to 445, this means the patient is having thyroid storm, and the patient has to be admitted and managed emergently. And if it is 25 to 44, it is going to be impending thyroid storm. And if it is less than 25, it is less likely to be thyroid storm. So whenever we have some doubt based on this, some symptoms or signs, that whether we want to consider this patient as having thyroid storm, this scale is very useful. This is called as Birch-Wartowski point scale. The whole name is BWPS, Birch-Wartowski point scale. So just remember this name of this scale, UGO classification for Graves orbitopathy, and the clinical activities, not index, clinical activity score, CAS, for activity of the eye disease. So I know this is a bit confusing, but just think on it. It's actually not a very complicated thing. Okay, now whenever we have a patient who is having signs and symptoms related to thyrotoxicosis, okay, whenever we have a patient who is having signs and symptoms of thyrotoxicosis, what we'll be doing is, first, always we go for is TFT. And obviously all the I would say any cause of thyrotoxicosis will be having either free T4 increase or increased free T3. At least one of them would be increased. And majority of the cause will have decreased TSH. So this is very straightforward. I just told you there is only one cause where you will be having, increased TSH, that is TSH secreting adenoma. Otherwise, in all cause of thyrotoxicosis, we will be having increased free T4 or free T3 and decreased TSH. Okay. What are the other investigations? So based on the cause, based on the etiology, we'll be doing other investigation like TSH receptor antibody. Then you may go for USG thyroid gland. Then you may go for thyroid scan. Okay, which is mostly the technetium scan. Okay, technetium per technique scan. Okay, so based on the etiology that we are suspecting, we can decide on doing further investigations. Okay, so this is a simple algorithm from the Harrison. So start with measure TSH unbound, also unbound UT4, or it is same as free T4. Okay, if TSH is low, if T4 is high, there is no doubt that we are dealing with primary thyrotoxicosis. And if we have classical features of Graves' disease, like I just told you, orbitopathy, if we have classical features of, yes, dermopathy, or very rarely I would say acropathy. So classical features suggestive of Graves' disease that we have, actually speaking, just to confirm, we go for TSH antibody testing. But even if we don't do, not for diagnosis, I mean to say that if we don't do the diagnosis, you can definitely do by all these features. But remember, TSH antibody has to be done before the treatment for future, like to decide the management in the future. I will come on to this point in the later slides. Okay. If there are no classical features of Graves' disease, now you have doubt. Obviously, you will do this antibody testing. Apart from this, you can go for USG and thyroid scan and decide on what is the diagnosis. Either it will be toxic adenoma, okay, or it will be toxic MNG. Now, say for example, if the thyroid scan shows diffusely decreased uptake. Now, I just want to make one point about the thyroid scan here. So what basically is thyroid scan? We are giving either radioactive iodine, or more commonly actually we use in India is technetium pertechnate, because it behaves like iodine ion only. So it is being taken up by the thyroid gland only if you have a something stimulatory signal. Okay, so mostly it will be TSH or TSH like substances. If they are present, which stimulate the uptake of the iodine or pertechnate per se for this scan, then only we will be having increased uptake. So what will happen is, so for example, if we have diffusely increased uptake, if we have diffusely increased uptake, it means that we are dealing with something. There is something called a TSH receptor antibody, which is stimulating the whole gland, and hence the scan is, the pertechnate ion is being taken up by the whole gland diffusely. That is basically a feature of Graves' disease. This can be also seen in TSH secreting adenoma. So it is very logical. Okay, the same feature can be seen in this, but this is very rare condition. So we won't be discussing that. For example, if you have just one single hyper functioning, or I would say the hot nodule, rest all part is actually hypo. Okay, hypo. So that we called as toxic adenoma. Third is if we have same multiple hyper functioning nodule, that is multiple hotspots in the thyroid scan, then we call it as toxic MNG. The fourth possibility will be no uptake at all. So no, or I would say reduced uptake, diffuse, no, or reduced uptake. This means that there is the cause is in a way that either we are having excessive T4 hormones from the outside or from some other tissue, or the our thyrotoxicosis is because of the increased release of T4 from the thyroid gland. Okay, it is not because of increased functioning of the thyroid gland. I hope this is very clear. So if we have low radionuclide uptake, and if we have history, just short history and all short, if we are having short history, then we should think of destructive thyroiditis like subacute thyroiditis, or it could be amiodarone induced. So all just we saw in the table. Okay, it could be iodine induced, it could be even radiation induced. So anything leading to destruction of the thyroid gland causing release of the T4 or T3 hormones. Okay, or very importantly, it can be because of the too much T4 from outside. It could be iatrogenic or it could be factitious. Okay, so I hope this is very clear. If you have something TSH normal to high and high free T4, then I just told you should think of TSH secreting pituitary adenoma. This is very rare. This I'm not discussing this. Okay, in general, TSH receptor resistance cause hypothyroidism. Only in few patient will be having symptoms of hyperthyroidism. Otherwise, majority of the patient are having TSH secreting, TSH resistance syndromes have hypothyroidism. That's I'm not discussing here in detail. And the last thing, if everything is normal, we should not think of this disorder at all. So the sign symptoms are maybe because of some other disorder. And if this is very important, subclinical is basically low TSH and normal free T4 or normal free T3. This is basically subclinical hyperthyroidism. In only actually first we have to prove that it is persistent subclinical. So we repeat after 6 to 12 weeks. If it is subclinical, that is low TSH, normal free T4 T3, then in only specific situation you will be treating this subclinical. We'll come on that afterwards. So I hope this is very clear. Now we'll be discussing all the diagnosis of only Graves' disease. How do we diagnose Graves' disease? First, we'll be obviously doing this, no doubt about this. So low TSH, normal free T4, free T3, and we have, this is called as subclinical hyperthyroidism. Majority of the patients symptomatic will be having this. Okay, so low TSH and increase free T4 and free T3. In only a rare situation, you have normal free T4 but increased free T3 because of increased conversion from free T4 to free T3. T4 is actually normal, but what you get in the blood is increased free T3 level. That is called as T3 toxicosis. This is less common, but though a well-known entity, without any doubt. So once we know that it is primary hyperthyroidism. Okay, to prove Graves' disease, we have to go for first is serology, that is TSH receptor antibody, or many times called as TBII, thyroid binding inhibitory immunoglobulin. Okay, so it is almost same. There is some minor difference. We won't be going to detail of that. So either you call it as TRAB, TSH receptor antibody, you call it as TBII. Remember, if you are suspecting Graves' disease, it is almost always this has to be positive. Titer will vary, but it has to be positive. It is approximately 90 to 99% sensitivity and specificity is there. So if it is negative, you should always think of other cause of thyrotoxicosis without any doubt. There is no doubt about it. Okay, so it has to be positive, and it will be positive, highly specific and sensitive marker for diagnosis of Graves' disease. But many times we don't require it for diagnosis. Actually, we have the features of Graves' eye disease, but it is important to get a baseline titer and baseline whether it is positive or not. We should know that, especially the titer value is important. So it's called as Graves' hyperthyroidism. Okay, And if it is negative, always think of some other cause of hyperthyroidism based on the clinical scenario. If it is short history, less than 3 months, think of subacute thyroiditis. If it is long symptoms, and if you have a single palpable nodule, or if you have multiple palpable nodule, there is multinodular goiter on examination, you should think of other cause also. And what you will find on thyroid imaging or in the ultrasound examination in case of Graves' disease. So in Graves' disease, just remember this thing. USG in Graves' disease, there will be diffusely hypoechoic, and increased size. So you have goiter. That is, it's a clinical part. Goiter is a clinical part. But on USG, the size will be diffusely increased, not locally. As you don't have a single nodule or multiple nodule. It is usually a diffusely hypoechoic and increased size. And secondly, you can have increased Doppler. On color Doppler, you will see increased flow. Okay, increased flow on the color Doppler. So this is what you find on USG of Graves' disease. Say for example, if it is not Graves, what will say for example, if you're dealing with MNG, you will be having multiple nodules on USG. If you have toxic adenoma as a cause of hyperthyroidism, we'll have single. Mostly, so this is very important. In a patient who is having multiple nodules, only it is possible that you have only one nodule which is functioning. So the proof that only we have one functioning nodule, that we get only after we do the thyroid scan. I hope that is very clear. So if you have a single nodule, and if you have the symptom and signs of hyperthyroidism, you should think of toxic adenoma as the cause of it. Okay, and obviously USG is also done to look for, to look for any features suggestive of malignancy, especially when it is nodular. Okay, this is the reason it's been written. Note, when you have nodules less than 2 centimeter, here in this case, it is rarely going to be malignant. It is rarely going to be malignant. When only if you have nodules more than 2 centimeter, you go for thyroid scan and further investigation, local in terms of FNAC and everything. Especially if you have features suggestive of malignancy, only then we go for all these things. Okay, if the size is less than 2 centimeter, so no need to do any further investigation in this case. Okay, when we're suspecting Graves' disease, I hope there is no doubt about this. So just summarizing this, Graves' disease, what you will be having first: signs and symptoms of thyrotoxicosis in general. You have sign symptoms of Graves orbitopathy. This is seen only in 20 to 25%. Okay, not in all patients. But if it is present, it is like almost diagnostic for Graves' disease. And very rarely you have Graves dermopathy and acropathy. These are very, very rare. So most important is this. Then on TFT, you have low TSH, increased free T3, free T4. Then USG, you have goiter, that is diffuse enlargement, diffuse hypoechoic lesions. It is diffusely hypoechoic, increased vascularity. Okay, and last is on the thyroid scan. What we expect is diffusely increased uptake. Remember, usually these four are sufficient to confirm diagnosis of Graves' disease. And very importantly, I forgot to mention TSH receptor antibody testing, TBI, also called as TBII, thyroid TSH binding inhibitory immunoglobulin, or thyroglobulin binding, thyrotropin binding inhibitory immunoglobulin. Okay, this is positive. Okay, titer will vary. Low titer, the titer actually have very much importance. Higher the titer, less the chance of remission. Higher the titer, more is the risk of Graves orbitopathy. Okay, so this is very important. So we need to have baseline titer for all patients with Graves. So TFT, obviously it is compulsory. This is compulsory for all. And in general, you should also go for a USG scan initially. Okay, thyroid scan is not compulsory. Okay, this is done only if you have suspicion of malignancy or some other cause of thyrotoxicosis. Okay, this is very very straightforward. Now, when we come to the management of Graves' disease, so when we come to the management of Graves' disease per se, okay, so we have three options. Remember, we have just three options. Either it will be anti-thyroid drugs, or it will be, yes, it will be radioactive iodine, or it will be thyroidectomy. Okay, only three options. One is surgical, that is thyroidectomy. Second is radioactive iodine therapy, and third is anti-thyroid drug. When I say anti, it is basically we're thinking about thionamides. That is methimazole, carbimazole, and the PQ, that is propyl thiouracil. Now, how should we approach a patient with Graves' disease? Initially, we'll be discussing about the non-pregnant adults. Then we'll come on to the specific situations. Remember, the initial management. I'm talking of Graves' disease specifically. Okay, not all cause of thyrotoxicosis. At present, we are discussing about the management of Graves' disease per se only, not all causes of thyrotoxicosis. So, initial management. This is the drug of choice, or I would say treatment of choice for all initial. I'm telling initial management. Initial management in all patients. First line management is going to be anti-thyroid drugs without any doubt. Okay, what drug to choose? We'll be discussing that. Now, what is the I would say what are the advantages and disadvantages of using one over the other? I would say initial therapy always going to be ATD. No, not a single patient is going to prefer radioactive iodine or surgery. Only in specific scenario, patient will prefer this management. So it is always patient oriented management. In this case, it is always going to be you have to ask the patient to give all the options and tell them about what are the advantages of antithyroid drugs, disadvantages of antithyroid drugs, advantage of radioactive iodine, and advantage and disadvantage of surgery. Okay, so what is the typical? So when we come to remission, so initial remission will be like, so in surgery, maximum remission will be there in surgery. No, so we remove the thyroid gland, patient will always go into remission, but there is always a risk of permanent hypothyroidism lifetime. So patient will have to take T4 or T4 lifetime. So majority of the patient do not initially prefer surgery. Radioactive iodine, yes, definitely it can be used, but in general, the thing is because of the risk of radioactive iodine, some specific risk, though it is not very much a risky drug, but some specific risk and some specific concerns, many patients deny at the onset of treatment with radioactive iodine. Now, remember this thing. If we are thinking of radioactive iodine, just remember one important thing. This you need to know important absolute contraindication. First, absolute contraindication of radioactive iodine. First is pregnancy. Second is lactation. Third is moderate to severe or more active Graves orbitopathy. And fourth, it is relative contraindication. Nowadays, we have started using pre-pubertal males, or males, pubertal children. In general, we can it's not an absolute contraindication, but in general, we do not prefer to use radioactive iodine before puberty. After puberty, it can be used. So in general, less than 12 to 14 years, we avoid using it. So these are the three absolute contraindication: pregnancy, lactation, moderate to severe, at least moderate to severe, or it can be sight-threatening, active Graves orbitopathy, and pre-pubertal children. Otherwise, this can be used in all other cases. Please remember this cannot be used. This can be used, but we don't prefer it. So ATD are very well safe in Graves orbitopathy. When we have elderly with comorbidities who cannot withstand surgery, we don't prefer this. Okay, ATD can be used, no problem with radioactive iodine. Patient who is having surgical risk, same. This cannot be used. You cannot use this because both you can use both of this. Now, any patient who is having active liver disease, obviously everybody knows all the ATD, that is PTU, are contraindicated. You cannot use those drugs. But radioactive iodine can be used. This can be used, no problem. If a patient develops a severe hypersensitivity reaction to any of the antithyroid drug, propylthiouracil or methimazole or carbimazole, this is contraindicated for lifetime. So as such, at the onset, there is no contraindication of antithyroid drug. Okay, but once patient develop a severe or significant hypersensitivity reaction to any of the one agent, none of the agent can be used for lifetime. Then you are left with only two options, this and this. Okay, now this is just remember this two parts, no, like this three you have to remember. In this scenario, radioactive iodine is preferred. Okay, in patient who are having pulmonary hypertension, hypochondrial pediparalysis, and previous neck surgery or radiation, this is preferred, though this can be used in all, no doubt, no problem with it. But these are in general not the first line in these cases. Patient who develops recurrent hyperthyroidism even after stopping the antithyroid drugs, so you have these two options. Now there are some scenario where you actually directly go for surgery. Say for example, if a patient has a great deal about cosmetic purpose. He or she wants that my gland is very big, I want to get it removed, then obviously you have to go for it. Otherwise, this three, if you are suspected malignancy based on USG feature or FNAC feature, you have to go for surgery. Same way, large thyroid nodules have higher risk of being malignant, so you go for surgery at the onset. And coexistent hyperparathyroidism, say a patient who is in PTH adenoma, so you already are going to remove basically you are going to do surgery for this, so you will remove thyroid gland simultaneously. Okay, so I hope this is very, very clear. And surgery that we prefer, it is mostly it is going to be total, not near total. It is usually total thyroidectomy. Okay, so you have a patient first time, or I would say newly diagnosed. This is newly diagnosed Graves' disease. So all patients will be on. Yes, all patients will be on. So remember, just now coming on to this antithyroid drugs, then after we'll come on this chart. So antithyroid drugs are three, everybody knows. I just told you: PTU, methimazole, and carbimazole. Okay, the mechanism is basically TPO inhibition, which leads to all these things. Apart from this, we have T4, T3 inhibition at the higher doses of propylthiouracil. The main mechanism is this TPO inhibition, thioperoxidase inhibitors. Okay. Now, this is now very, very important to understand what is the difference between these two agents. Before this, I will just make one important point. So in all cases where you are using ATD, methimazole or carbimazole is the drug of choice without any doubt. It is going to be any one of this, either methimazole or carbimazole, no problem with anything. Both are basically pro drug. One is pro drug, one is like active drug. Basically, this is the pro drug, this is the active drug. So, except remember this exception where you will use PTU. So one absolute indication of PTU is for 16 weeks of pregnancy. So basically, first 16 weeks, some say first trimester, but it is actually practically and as per the guideline, it is first 16 weeks of pregnancy, it has to be propylthiouracil. No doubt of this is the main indication of propylthiouracil. Apart from this, some patient who has developed some minor or less life-threatening allergic reaction to methimazole or carbimazole. So I'm not telling the severe reaction. Any less than severe reaction, you can actually substitute methimazole with propylthiouracil. Second. And third, during thyroid storm. During the management of thyroid storm, propylthiouracil can be preferred. I'm telling can be preferred. It is not like you have to use this only. If you're using this, you have slightly added advantage in terms of this mechanism. T4 to T3 conversion, it inhibits this. That's why you may prefer propylthiouracil during the thyroid storm. Otherwise, it is methimazole or carbimazole in all other situations, including children. In children, propylthiouracil is not indicated at all. A very high risk of hypersensitivity reaction in children. Okay. Now, so I just made that very clear. Now, this is a big table. You can go through it completely, especially the pharmacokinetic and all those part. I just want to specifically mention some things. Okay. Okay. So main is this. Remember this thing. So in patient who is having liver disease, the duration of this drug is prolonged, increased action. That's why you have to decrease the dose. In patient who is having, if you're using this drug in active liver disease, ideally you should not use. But when you don't have any other option, if you're using methimazole, the dose has to be reduced. Okay. Now, everybody knows methimazole is much more potent than propylthiouracil, 10 times more potent. That's why the normalization of T3 and T4 is as early as 6 weeks as compared to propylthiouracil, which takes around 12 weeks. Okay, this is very important. Both cross placenta, both have the, like, it's not like P2 is 100% safe in terms of pregnant individuals. But the thing is, if you don't use any drugs, so radioactive iodine is absolutely contraindicated surgery. Usually nobody will be doing surgery in pregnancy in general. So you have to use any of the three drugs, either methimazole, propylthiouracil, or carbimazole. So what is it? Basically using the less, I would say less, the drug which is having less ADR or less teratogenicity. So earlier, what we before many years, it was like propylthiouracil was used for whole pregnancy, but then it was found that there was very much high risk. There was very much high risk of, yes, there was very much high risk of PTU induced hypertoxicity. That's why its use has been limited to first trimester, or precisely it is up to 16 weeks. So we use as comparatively more safe drug after 16 weeks. That is methimazole or carbimazole. Okay. Now, just I would come on this now. So if you have a patient who is having first time diagnosed Graves disease, so remember that. So I'm just giving you overview for a patient who has come to you first time diagnosed Graves disease. You want to give, you are like you have decided to give antithyroid drugs after discussing with the patient, and you have decided to start either methimazole or carbimazole. Obviously not propylthiouracil. Now, what is your aim? Obviously, first aim is obviously the treatment of the patient. Second is you want the patient to come in remission. Okay, I hope I'm making sense, because in general, I'm not saying all patients, some patient will actually achieve remission, and you can actually consider stopping antithyroid drugs after some time. Okay, after some time you can consider stopping this, stopping drugs. That is something called as remission. Okay, something called as remission. Okay, so we have one score. So it's okay, no need to remember this score. It's called as GREAT score. It is Graves recurrent events after therapy score. It's basically it's very, I'm just making it logical. Okay, lesser the age, if you have lesser the age, higher the free T4 levels, higher the antibodies, and larger the goiter, you have higher risk of recurrence. So you have the score made based on this. So this three scores, 0 to 1, 2 to 3, 4 to 6. So you can just predict what are the chances of recurrence in a particular patient even before starting the treatment. Okay, so just remember these 4 points. Lesser the age, more the risk of recurrence, or lesser the chance of remission. Higher the T4 values, lesser the chances of remission. Same, higher the value of antibodies, less chance of remission. More the goiter size, lesser the chances of remission. Okay, this is very simple. So now coming on to this. So remember, I just told you, lesser the age, less the chance of remission. So that's why it's been said in children, the duration of treatment, it has to be minimum 36 months. Then after, you can consider stopping the drugs after considering something, what we will see afterwards. In adults, it is going to be minimum 18 months. Okay. Now you have a patient, who you have prescribed this. See, a patient is having methimazole, a adult 18 months you have given. Now what you will do, you already have one value of this, or you can say this, it is same. After 18 months, what you will do, you will get a repeat done. If this is negative, if it obviously it will be positive here, if it becomes negative here, you can stop. You can stop medications and monitor. Okay. There are chances that some patient may relapse and some may be in remission for longer times. So if patient again gets the sign symptoms and again patient gets low TSH, increased T3, T4, in that scenario, you have to consider patient as having relapse. Now, second option, some say, is if the antibody is positive at this stage, if antibody is positive even after 18 months, what you do is you give the patient option. Either patient can go for definite therapy, radioactive iodine, or surgery, or patient may opt for low dose methimazole continuously. The two options. This is less studied. This is less studied, but still, if patient doesn't want to go for radioactive iodine therapy, patient does not want to go for surgery, in that scenario, you can consider giving continuously low dose methimazole. Okay, but this is less studied. That is the only point I want to make. Now, so I hope I'm making this sense. So again, going to the same algorithm, same table. New onset, you give methimazole. Now, there can be some scenario where patient actually develops intolerance. So any severe complication, severe hypersensitivity reaction, or any reaction that patient does not want to go continue. He may develop severe itching, some rash, which we consider that patient is not having severe ADR, but patient does not want to continue. That is something called as intolerance, and patient does not want to continue it. Then you have to go for this or this, radioactive iodine or surgery, thyroidectomy. I just told you again, I just told you this here only. If somebody does not want to go for long-term therapy, he want that just in one time, my treatment should be complete. So he wants to go for surgery for that purpose, but he needs to understand that he or she has to take thyroid hormone replacement for life after surgery. So for example, you have a patient who is not tolerating any of the antithyroid drug, who is having active eye disease, and you want to treat his condition or his symptoms. The only option you are left is with surgery. Okay, I hope I'm making sense, right? Because radioactive iodine therapy is absolutely contraindicated in moderate to severe active eye disease. Okay. Now, there is something called as persistent hyperthyroidism. At the end of 18-month in adult and 36-month in children, you have persistently positive antibody. I just told you. There are two options. Either the patient can go for definitive management in terms of this or this, radioactive iodine or thyroidectomy, or patient can further continue low dose methimazole or carbimazole. And again, patient can consider measurement of yes antibody. If it comes negative, you can stop. If it is for continuously positive, you can have to go for definitive management in terms of radioactive iodine or thyroidectomy. Now, say for example, patient had achieved relapse here. See, you stopped here. After some months, he again develops the disease, that is relapse. In that scenario, what you can do is either patient can go for long-term low dose, that is less studied, I just less studied, or you can go for radioactive iodine or thyroidectomy. So now I hope I'm making sense here. There should not be any doubt. This is very important main and adverse drug reaction of the commonly used drug, this antithyroid drugs. Okay, so all the three drugs are known to cause various forms of hypersensitivity reaction, but there are some differences. See, like when I say hepatotoxicity, it is obviously more severe and more dangerous with propylthiourate. That's why it carries the black box warning for that. So that's why we don't prefer to use propylthiouracil except in first 16 weeks of pregnancy. And all other cases, you prefer carbimazole, methimazole only. So you have one typical drug, one typical condition called as hypoglycemia. It's very rare, but very typical ADR. Patient develops anti-insulin antibody. It is more commonly with methimazole because hyperthyroidism is rarely used nowadays. What happens? Patient starts taking methimazole, he develops anti-insulin antibodies and develops hypoglycemia. Okay, and actually the antibodies are not anti-insulin; they are basically like insulin. They bind to insulin receptor and act like insulin. The patient will develop hypoglycemia after starting methimazole. This is very rare idea, but just it's actually called as Hirata syndrome. Okay, then you have this. I just told you, na, hepatitis is more severe with this, but it can occur with carbimazole, methimazole also, but it is usually in terms of cholestasis. Okay, cholestasis. Now, the most dreaded complication that we worry about is it is agranulocytosis. These all things are minor and they are manageable with some like using antihistaminic or something like that. But main concern for us is agranulocytosis. If patient develops this, you can never use any of the three agent for life. If patient develops aplastic anemia or ITP like picture or vasculitis, lupus like syndrome, you cannot use any of the drug. Okay, this should be very clear. Then you don't have the option of using antithyroid drug. You have to go for either radioactive iodine or surgery. You cannot use this thing. Now, this is the specific therapy. Apart from this, what we usually use is, yes, what we usually use apart from this is beta blockers. Beta blockers are always, if they have to be used, always used. They're always used because they definitely provide a great amount of symptomatic relief for the patient. And the main reason is the antithyroid drugs take some time to act. So in the rapid management or initial management definitely will be helped by beta blockers. Okay. So mostly it is going to be either propranolol. If that is contraindicated, the dose usually is 20 to 40 mg QID. If the preparation is sustained release, you can actually use BD dose also. But the typical preparations are having less half-life, so you have to go for less duration of action. That's why you have to go for QID dosing. If patient is having asthma or some other obstructive airway disease, so you want to avoid using non-selective, you can go for selective beta blockers like metoprolol, atenolol. You can go for bisoprolol, whatever, if propranolol is contraindicated. So, and high doses, especially doses of 40 mg QID, this is additionally inhibit the conversion of T4 to T3. That's why at this high doses, it is particularly used in cases of thyroid storm. Okay. And in case of thyroid storm, you also can use steroids. Okay, steroids are very much helpful because they also inhibit the conversion of T4 to T3. Okay. And one more group of drug that actually particularly is used in case of thyroid storm and typically used before thyroidectomy. It is the iodide group of drugs. It is fastest acting. It acts very rapidly. And secondly, it decreases the vascularity of the gland. So very much it is helpful before surgery. Okay, this is the iodide group of drugs. Also, we use the drug that is called as Ligol's iodine. So it is available in form of solution, or many times you have to prepare the solution and you have to give. Okay, though it is used in thyroid storm and before thyroid surgery, thyroidectomy. We have one more drug. Occasionally, we use this drug, cholestyramine. It binds the like some part. It binds. See, some part of it is bound from the GIT, and it prevents the reabsorption of thyroid hormone. So, especially in cases when we cannot use any other drugs, so in that time, temporizing measure, we can use this drug that is cholestyramine. So, not for long-term management, is only for temporary management. Okay. Now, I hope I'm clear till this. Last is now coming on to the radioactive iodine therapy. We already have discussed about this. I'm not going to discuss about the dose and all those regimen about this. Just remember, it is particularly not used in, remember, pregnancy, not used in lactation, not used in pre-pubertal children. So this is not an absolute contraindication. Nowadays we are using in children also, but though it is in generally avoided. That is the only thing. But this is absolute contraindication. And the two most important, I would say, risk factors or precipitating factors for the Graves' orbitopathy are: first is radioactive iodine, and second is smoking. Okay, smoking and radioactive iodine are the two most important risk factors for the development of Graves' ophthalmopathy or Graves' orbitopathy. So moderate to severe active eye disease is a absolute contraindication for using radioactive iodine therapy. Okay. Then last option is thyroidectomy. I just discussed earlier also the advantages of thyroidectomy. The main thing is no recurrence, not possible because the gland is not there. No radiation risk, the rapid control, no reported detrimental effect on the course of. So basically, uh, it does neither it increase the risk nor it decrease the risk of Graves' orbitopathy without any doubt. Okay, so basically, if patient is having active Graves' eye disease, it is neither a contraindication or an indication. ATD are in general preferred because they decrease slightly, help in controlling the eye management also, and they will control the hyperthyroidism part also. Second, the main is the disadvantage. So first is risk because of surgery. This is very important. The cost, hospitalization, permanent scar, and the local complication in terms of post-operative hyperparathyroidism, recurrent nerve palsy, permanent high. This is going to be happen in all. So permanent hyperthyroidism, it is going to happen in all patients. So it will be lifelong T4 replacement after surgery. So patient should be counseled from like beginning only. They should be knowing this. But the thing is, giving T4 replacement is very easy and it does not have any adverse drug reactions as compared to radioactive iodine, as compared to antithyroid drugs. So many times patient will like agree with this only, and many times we don't have any other option also. So I hope this is very much clear. Now, special scenarios. I just told you in pregnancy and lactation, radioactive iodine contraindicated. Okay, first 16 weeks of pregnancy, propylthiouracil. Then you have to use carbimazole and methimazole. And then third thing is there is important is neonatal hyperthyroidism. So it is usually transient, but it is a definite entity. It has to be picked up. The thing is, this depends on the TSH receptor antibody levels in mother during pregnancy. Okay, this will depend on this. So you have to check for this levels, and if there is some risk, you have to consider monitoring the neonate also, and then you can consider treating the patient also. Okay. Now, if what if the patient is having Graves' orbitopathy, active coexisting Graves' orbitopathy? Remember this thing. It is the activity of the disease. I have already discussed this part. There's two things. One is activity and one is severity. So that in that way, we had to classify into this form: mild and inactive, mild active, moderate to severe and inactive, moderate to severe and active disease. So it is here that this is contraindicated. Okay, this is contraindicated. Now, what if a patient is having mild and active disease? This is remember, mild and active disease means only mild Graves' eye disease is there, but it is active. So in that scenario, prophylactic steroids, oral steroids, have to be used. Have to be used in patients having mild and active eye disease. Okay, in general we don't go for a systemic immunosuppressant, but if you're giving radioactive iodine therapy in those patients mild active disease, prophylactic oral steroids have to be used for management of eye disease. Okay. And the selenium, the only indication of giving selenium, I would say, this mild active disease for 6 months. Okay, selenium is used for mild active disease. Okay. Now, So just see this. I just told you there is no contraindication for use of ATTs in Graves' ophthalmopathy. That is helpful. That's why. But in active and especially moderate to severe active or sight threatening, this is absolutely contraindicated. This is not contraindication. I would say this is it is basically in the severe scenarios we don't go for surgery. That is the only reason it's been written no. Surgery can be done even in moderate to severe eye disease also, not a problem. There is no relation with that. Okay. Now, coming on to the children, I just told you in children, chances of remission are less. PTU is contraindicated. No way it should be used. Third thing is, in general, it is not absolutely radioactive iodine is relatively contraindicated. It can be used when we do not have the option. Relatively contraindicated. And it should be treated as early as possible because it has effect on the growth of the child. It should be treated early and very actively. Okay, to not waste time. Okay, so coming on to one important thing, we'll go for the afterwards. So you have something called as subclinical. You have low TSH and increased or normal free T4 and normal free T3. Okay, so when should you consider the absolute indication of treating subclinical hyperthyroidism is age more than 65 years and TSH less than 0.1. So this is the absolute indication of treating subclinical hyperthyroidism. If patient is having symptom, if he's symptomatic, then you can even consider treating at TSH less than 0.4 also. Okay, even in less than 65, but the decision has to be individual. In general, the most specific indication or most studied, I would say, evidence based in subclinical, it's age more than 65 years and low TSH less than 0.1. You have to consider treating the patient. Otherwise, if patient is having symptomatic and TSH is less than 0.4, even in age less than 65, you can consider treating the patient because he's symptomatic. Okay, just like summarizing the dose, like discussing all the dose. So mostly what is available is either methimazole or carbimazole or propylthiouracil. The dose is usually, so what is the concept? How do we treat? Earlier there was something called as so now we use only this regimen, titration regimen. Earlier we used to have one more regimen called as block and replace. So we used to give thyroid T4 and maximum dose of methimazole or carbimazole, so to in order to avoid hypothyroidism. Okay, but nowadays it is not being recommended. So it's simple. Now we use titration regimen. But what does it mean is you use moderate to high dose of these drugs initially. For methimazole it is usually 30 mg. For this it is usually 45 mg, and PTU it is going to be 300 mg per day. This is per day dose, and you monitor. This is now very, very important. How do you monitor? Very important. Monitoring is always by free T4, and if patient is having normal free T4 initially, only free T3 is raised, then you can use free T3. TSH is not used initially for monitoring because TSH level remains suppressed for a long duration, at least 3 to 12 months. They remain suppressed. They remain suppressed for a long time. So what we use for monitoring is free T4 or free T3 levels. Most commonly, this is the best marker for monitoring. So we monitor after 6 weeks, free T4. After 6 weeks, then after 12 weeks, once patient is euthyroid, that means if patient has developed, had got a normal free T4 levels, then you monitor 3 to 6 monthly. And then if regimen has been, then what you do actually is you decrease the dose gradually, 30 20 mg, you make it even 15, then 10, and even as low as 5 mg. Okay, similarly you go 200, then low dose 150, then 100. Usually it is going to be 50 to 100 mg per day. Okay, this is going to be this is called as maintenance dose. Maintenance. So you start at highest doses, then you gradually decrease once patient develops a euthyroid state. So this is usually a maintenance dose. Okay, so I hope this is very, very simple. Okay, so methimazole can be used, it is used in the OD dose. Carbimazole is actually slightly lesser, half-life is low. So either BD or TDS it is being used. Okay. And propylthyroxine is always used in TDS dosing. It is usually 100 mg TDS initially. Then gradually it is decreased. Okay. So this was all about the management of Graves' disease. So if at all anybody is having any doubt, you can ask in the chat section currently. Yes, if anybody is having any doubt, they can ask in the chat section. Yes. They can ask in the chat section of the YouTube, or they can definitely ask in the Zoom. Okay. So Avinash has asked one question, that what will we do if a patient comes in the thyrotoxic crisis or thyroid storm in the pregnancy in the third trimester? So I just told you, it is not like propylthyroxine has to be preferred for this purpose, for the purpose of thyroid storm. Like, it is not, I would say it is a preferred agent with respect to, in comparison to carbimazole and methimazole. But in general speaking, during third trimester, propylthyroxine should not be used. So carbimazole or methimazole will be used in addition to steroids, in addition to propranolol. Okay, Avinash. So in general, it is not like propylthyroxine has to be used in thyrotoxic crisis. It is just like it is preferred for the reason of prevention of T4 to T3 conversion. Nothing else. There is no other advantage of using propylthyroxine. Okay. Okay, Avinash. So yes, anybody is any other doubt? Yes. I just told you now. Prashant is asking role of steroid in thyroid storm. So definitely it has to be used, no doubt about it. And many times, many scenarios are there where you cannot use antithyroid drugs in thyroid storm because patient is having deranged LFTs, must derange LFTs, and surgery cannot be performed acutely. Radioactive iodine cannot be used acutely. So the steroid becomes the mainstay of management in those scenarios. Okay. And even in absence of, even if we are using antithyroid drug, steroids play a definite role because they inhibit the conversion of T4 to T3. Okay. There is definite role of steroid in thyroid storm, no doubt about it. Yes. Any other doubt? Any other doubt anybody is having? Yeah. Should we then end this class?
Yes, sir. I think there are no further doubts. It was a very comprehensive class. We definitely have a very clear regarding the management of Graves' disease. So there is one more question by
yeah.
Avinash.
Yeah, just a minute. So Hirata syndrome, I just told you. Yeah, he is telling Hirata syndrome is seen only by carbimazole methimazole. So the thing is, PTO is now not at all being used much commonly except in first trimester of pregnancy. Okay. So nowadays it is more commonly described with methimazole and carbimazole only. Okay. It is not like it is seen only with this, it can be seen with any of these thionamides, carbimazole, methimazole, or propylthiouracil. But most commonly it is described with methimazole because the most commonly used drug is methimazole. Okay. Okay. Any other doubt? So if anybody is having any other doubt, they can ask me, or even if those who will be seeing the video later on, they can ask me in the chat section of the YouTube. It will be like this video will be available always on YouTube channel, so they can ask me doubt later on also. I will be answering in the chat section only. Okay. So thank you for being with me. I know it's a bit slightly, it was a bit confusing thing in between. But the thing is, topic is that like many things are new for you, especially in terms of this course and all those things. But at least if you know the names of this course, it will be helpful. Okay. So I think we should end this session.
Yes, sir. So it was
Okay.
definitely a very helpful session. We have all our concepts very clear regarding the Graves' disease management. Thanks a lot for everyone to attend and for asking the doubts.